Let me just start by saying like a very warm welcome to everyone who has already joined and everyone else who will be joining. Welcome to, I think this is now the sixth session of the Global Sepsis Lecture Series. Um, as most of you will know, we have had a series now since the end of March. It's like a bi-weekly session, like focused on everything around sepsis, that is relevant for the Sub-Saharan African context. Very welcome to everyone. I will not talk too much. I will just say that today we have a distinguished speaker, Dr. Shevin Jacob from the Liverpool School of Tropical Medicine, who himself is based in Uganda, who is a reader for sepsis research, um, will talk to us today and will give us an idea about sepsis and also I assume the role of sepsis research in the sub-Saharan African context. I won't say much more, Shevin. I will just give the word to you if that's okay. Very welcome. Thanks for doing this. And please go ahead.
Yeah, absolutely my pleasure. Hello to everyone. Wiltruder Ellen, can you just remind me, is it an hour that we have together?
Yes,
Yes.
we're
Okay.
planning for an hour. I'll be glad if you leave us some time for discussion in the end. I
Okay.
always encourage people to put questions in the chat and we will go through them. Um,
Okay.
and even
Great.
be able to talk. Yes.
Okay. All right. So if anyone is having any trouble hearing me, I always have problems with my sound. So please interrupt or whatnot. But otherwise, yeah, truly a pleasure to be here and to join this community and be able to talk to all of you. This talk is really a whistle stop tour in terms of what we know about sepsis and sort of our potential gaps. And the potential gaps really are opportunities for sort of research across networks like this one. Where we really can spend important time kind of uncovering those gaps or filling those gaps, I guess. For this talk, I'm going to go through a number of different things, and hopefully by the end of it, you'll understand the epidemiology of sepsis globally. And I will apply this patient care continuum framework, and many of you who have heard me speak in the past will know what I'm talking about, but I'll discuss that a little bit. And that'll help us kind of frame how to kind of look at the different knowledge gaps for sepsis in low and middle income countries and potentially where to fill them. Um, and then I want to go through kind of what global evidence exists to help guide the management of sepsis. I will just give you a disclaimer that this sometimes the evidence does complicate how we might approach things. And then I just want you to be aware of existing evidence-based guidelines for sepsis management in resource-constrained settings. So before I go through things, I'm going to start with a case.
Kevin,
Yes.
can I interrupt you? Can I ask you to maybe go to presentation mode? Is that possible? Because right now we're seeing your PowerPoint.
Very sorry about that.
Don't worry.
Rookie
This is
mistake.
perfect. Thank you.
Okay. Um, so so starting with the case, let me just clear this from my screen. Okay. So Mr. Masoke, he's a 33-year-old Ugandan fisherman with fever and weakness, and he presented at a health center in southwestern Uganda with symptoms for the past 48 hours. And he was seen in a clinic, and a cursory exam was performed by the clinical officer. The officer noted that his temperature was 38.8 degrees Celsius. He had an elevated heart rate of 110 beats per minute and respirations of 14 breaths per minute. He ended up getting sent home with a diagnosis of malaria and a 3-day course prescription for anti-malarial treatment. There was no blood smear or rapid diagnostic test that was performed. And ultimately, Mr. Masoke was unable to fill his prescription due to cost. So, unfortunately, his condition worsened overnight. And the next day, he woke up with ongoing fever, malaise, generalized myalgias, and dizziness when standing. So he and his wife traveled 3 hours by bus to the closest regional referral hospital for further evaluation. And his exam was remarkable for the following. He appeared unwell, he was unable to stand without assistance, and he was able to respond to questions but was somnolent. His vital signs were significant for still having a fever. He was still tachycardic, and now they checked his blood pressure, and he was found to be hypotensive with blood pressure of 90 over 60. On exam, his oral mucosa was dry, and he had confluent white patches on the surface of his oral mucosa. So if we were in a classroom, I'd be asking you all a bunch of questions to try and see, what your thoughts are about Mr. Masoke. And I'm sure you have many different questions kind of going through your heads. And let me try and read your mind. Potentially, some of these might include, what information about his past medical history would be useful? What lab tests would you consider to try and narrow his diagnosis? How would you approach his clinical management? And what are his chances of surviving in the hospital? And if he's discharged in the ensuing months? And of course, given this topic of this presentation, could Mr. Masoke have sepsis? So I think all of us who are coming here know what sepsis is, but it's always good to kind of just remind ourselves of the kind of formal definition and also understand who's at risk. So sepsis is a medical emergency, and it is defined as life-threatening organ dysfunction due to a dysregulated host response to infection. And this infection can be caused by any type of pathogen, whether it's bacteria or parasites or fungi or viruses. And oftentimes we talk about, to many of our other clinical colleagues, if you ask them who's at risk for sepsis, it's usually attributed to mothers in the peripartum sort of period and neonates. But we also must remember that sepsis can affect anyone around across the life continuum. And so from adolescents to adults to the elderly. And in particular, we have to remember patients who are at risk for immune compromise. So because they're at risk for worse outcomes. Globally, we know sepsis is an important problem. We've seen this map of from the global burden of disease on the burden of sepsis mortality across the globe. And as you can see in the areas with the dark blue and green sort of mosaic, that has the highest burden of mortality, and most of that is concentrated in Sub-Saharan Africa. And so overall, globally, in 2020, there was 14 million deaths were reported globally, and 30% of those occurred in Sub-Saharan Africa. And we know that there's an association between sepsis and HIV in Sub-Saharan Africa. There's been a systematic review done to look at community-acquired sepsis in Sub-Saharan Africa, and the majority of people were people living with HIV. Mycobacterium tuberculosis was the most common cause of bloodstream infection, and I'll come back to this in a moment. The pooled in-hospital mortality using the sepsis 2 definition, which you'll know about more in a moment, was sepsis was 19% and severe sepsis approached 40%. And there was an increase in in-hospital mortality associated with higher proportion of HIV infection. So in that context, sepsis, the global importance of sepsis was addressed at the World Health Assembly in May 2017. And a resolution was passed to make sepsis a global priority, where where the resolution was to improve, prevent, and the prevention, diagnosis, and management of sepsis. And all of the member states ratified this resolution to implement measures to reduce human health and economic burden of sepsis. Last year and again this year in the World Sepsis Congress, the DG, Dr. Tedros from the WHO, said that nobody should die from sepsis. And I think along all of this, we can relate no matter what context we're working in. I happen to be, even though I live in Uganda, I happen to I got to Liverpool today. So whether I'm in Uganda or Liverpool or for any of the settings where all of you are calling in from, we have, our patients need to get from their homes, to the health facility to get the definitive care that's going to improve their outcomes. But oftentimes there are a number of barriers that along that journey from home to the health facility and back. And it's through this continuum where we can start to tack on specific areas where there are indeed gaps in our knowledge, but also opportunities for trying to understand those gaps or fill those gaps with research. So these gaps can include, or the areas include, early recognition and triage, diagnosis, early appropriate treatment, monitoring and ongoing treatment, and recovery and rehabilitation. So for the next several slides, I'm going to go through these various kind of areas of the sepsis care continuum and talk about the evidence that we do have and potential gaps that, we have the opportunity to fill. So to start with, early recognition and triage. I just wanted to kind of remind us all of the evolution of the sepsis definition. So the sepsis 1 and 2 definition really looked at sepsis as a spectrum of disease that evolved, or that sort of gradually went from sepsis to severe sepsis to septic shock. And in this definition, sepsis is defined as having any two of the following SIRS, or systemic inflammatory response syndrome, which as we know is aberrations of vital sign measurements like temperature, heart rate, respiratory rate, and then also looking at the white cells as the kind of response to infection. And so having any two of the following of the SIRS criteria plus the suspected infection was the definition of sepsis. And then if somebody had organ failure as well, that plus sepsis was defined as severe sepsis. And then when a patient had organ failure and refractory hypotension, so that's refractory hypotension plus severe sepsis, that was defined as septic shock. So in 2016, this definition was revised to the definition that we talked about earlier today, and where it really is this combination of suspected infection, organ dysfunction, and a dysregulated host response. And the definition is based on the SOFA score, or the Sequential Organ Failure Assessment score. So the panel, that score is there on the right side of the panel. And if you have an increase of 2 points or more in this SOFA score, you have an increased risk for mortality due to sepsis. And the quick SOFA score, which was not a definition, but it was meant to be a tool that could potentially prompt you to further diagnosis or treatment, is the components of the Q-SOFA score there on the bottom right, where patients have hypotension, altered mental status, and tachypnea based on those cutoffs. And if you have a Q-SOFA score, that again would guide further management or diagnosis. And this, to round it out, septic shock is sepsis, and despite having adequate volume resuscitation, both of persistent hypotension requiring vasopressors and elevated lactate. So this is kind of what the sepsis 3 definitions cover. And so what is the performance of, sort of the SIRS and Q-SOFA for predicting sepsis and mortality? So just to show, I think in this figure, above you see sepsis 1 and 2 definition, where sepsis and infection really overlap quite a bit, right? And so patients with sepsis, oftentimes in the older definition, the reason why the older definition was criticized a bit was because it wasn't fit for function. It didn't allow us as clinicians at the bedside to determine whether this patient who has, a suspected infection and maybe a fever and elevated heart rate, is having a medical emergency, and whether we need to be very aggressive in their care, or, whether they're just having a transient fever and they have a mild illness. And the change in sepsis 3, as you can see depicted in that lower figure, is that sepsis is a very small subset of infection, and it definitely represents that group of patients who are fulfill criteria for a medical emergency. So in this case, all sepsis is a medical emergency, and therefore, in the sepsis 3 definition, severe sepsis, that term is now removed because you don't need to say it anymore, because when you think of sepsis, you should be thinking severe. There has been some analyses to look at the performance of these scores, and as you can see, when trying to look at the performance of SIRS versus SOFA in identifying patients with sepsis, SIRS does a pretty good job, but when you want to look at mortality, QSOFA performs better. And let's say more about QSOFA in terms of studies that have been done. So the Sailors study, which was led by Christina Rudd and published in JAMA in 2018, was a retrospective study of just over 6,500 hospitalized adults with suspected infection. And it comprised patients from across 10 countries in low and middle-income countries, from Sub-Saharan Africa, Asia, and the Americas. And it compared the predictive validity for hospital mortality, which is a proxy for sepsis, using models of baseline risk versus baseline risk plus SIRS versus baseline risk plus QSOFA. And here, baseline risk is based on age, sex, HIV status, and transfer status. And as you can see from these area under the ROC curves, the baseline risk plus QSOFA model had the best performance compared to baseline plus SIRS or baseline alone. But let's be honest, a baseline or an area under the ROC curve of 0.7 is not great performance. And as you'll see later, it's this kind of result that sort of has led to some of the recommendations about what we do with QSOFA in the management of sepsis patients. So more on that soon. And I'll just mention another score, the Universal Vital Assessment, or UVA score. And this was a score that was derived and validated from pooled data from hospital-based cohort studies that were conducted in 6 countries in Sub-Saharan Africa, and they corresponded to just over 5,500 patients. The age of these patients were in the mid-30s. About a third of them were HIV infected, and in-hospital mortality was just under 20%. And here you can see that the UVA score, which comprises all of the elements on the left there, so looks familiar, I think, in terms of the SIRS criteria, but also includes Glasgow Coma Scale and HIV infection. And as you can see in that bottom panel, as score goes up, the odds ratio of death increases. And the performance of the UVA score to QSOFA was greater in that particular study. So it's an important score to be aware of. It wasn't validated or derived in the same way as was done in the Sailor study, but definitely comes up, I think, when talking about validated scores within this setting. And then I'll close this out with just definitions that have been developed for low and middle income countries. So the WHO back in 2011 published the first sepsis sort of guidelines from the WHO in the Integrated Management of Adolescent and Adult Illness, or IMAI District Clinician Manual. And the sepsis definition was a kind of modified SIRS criteria, so suspected infection, blood pressure less than 90, and one of the following, the heart rate greater than 100, respiratory rate greater than 24, or aberrations in temperature. And the IMAI District Clinician Manual was updated for the Southeast Asia Regional Office during COVID. And as you can also see, the definition for sepsis in the IMAI District Clinician Manual was updated to correspond with the Sepsis 3 definition. So ultimately, I think, we have these definitions. We haven't really looked at implementation of these definitions, sort of in a systematic way across many low and middle income countries, particularly in Sub-Saharan Africa. And so in order to really determine whether these are sufficient or whether they require refinement, we need to conduct research to look into this question better. So I'm going to move on to sepsis diagnosis, the next area. And so this figure is showing a study from John Crump and colleagues, where they actually did the study in both adult patients and pediatric patients. So I'm showing the figure from the hospitalized febrile adult patients from Tanzania. So there's about 400 patients. And so I think the first thing to say, and perhaps many of you can relate to this, is that among the 400 patients, just over 60% of those patients were suspected to have malaria. But when definitive testing, whether it was blood smear or rapid diagnostic tests were done, malaria was only confirmed in 1.6%. And then it should be noted that bloodstream infection was found in about 28% of infection. No diagnosis in about a third of those patients. And importantly, zoonotic diseases in this particular area of Tanzania were responsible for 40% of the patients. So that includes things, sort of pathogens like the rickettsiosis, chikungunya, Q fever, leptospirosis, and brucellosis. And so the importance of serologic testing and other molecular testing is critical to really try and uncover these diseases, which you are not going to be able to uncover with conventional methods. And here's some data from one of our original studies almost 20 years ago in Uganda, where we enrolled adult patients with sepsis. And as you can see here, about 25% of the patients had TB in their bloodstream. And so I think it's really important for us to know, particularly among patients living with HIV, in a number of different studies, that TB, when tested, is the most common cause of sepsis and bloodstream infection in adult patients with HIV. And we did a patient-level systematic review and meta-analysis. And in this meta-analysis, we were able to show in about 2,500 patients that patients with TB bloodstream infections had a significantly greater hazard ratio for mortality compared to patients who did not have TB bloodstream infections. And also, just kind of going back to the previous point, as you can see from our study, we also had negative cultures in a considerable number of our participants. And in those participants, we ended up doing molecular testing to try and understand what might be the cause. And there was quite a spectrum of pathogens that we were able to uncover. As you can see, the most common was CMV, which in previous studies, not from our group, but from elsewhere in the world, has shown that cytomegalovirus is a kind of a bystander pathogen in critically ill patients. The role in terms of pathogenesis, though, particularly in HIV infected patients, is not well understood. And then we were also able to uncover, diseases like dengue and rickettsial species that otherwise we would not have been able to see in the blood cultures that we obtained through our study. So I'm going to move on to from pathogens without, if we're going to be thinking about sepsis and etiology, we also need to recognize the importance of antimicrobial resistance in sub-Saharan Africa. In this study in the Lancet from 2019, published in 2022, this figure shows the mortality due to drug-resistant infections based on regions of the world. And as you can see in the left part of that graph in the green sort of bars, those are all regions of sub-Saharan Africa. So the greatest burden of mortality due to drug-resistant infections is in sub-Saharan Africa. And these updated data from, I think, 2021, this is in the Global Burden of Disease group from from the Institute of Health Metrics and Evaluation, show that composition of infection-related deaths in sub-Saharan Africa, with about 5 million deaths overall. And where you see that, sort of attributable and associated resistance and seen in over 1 million of those deaths. But still a significant proportion are not resistant. And so really important to know that of the deaths that are, sort of contributing to this high burden of mortality in Africa, a significant proportion are drug resistant. And just to highlight this point, our CEO of the Global Sepsis Alliance, Dr. Mariam Joshi, has said now in a number of different places that the face behind every AMR-related death is a face of a child, a woman, or a man suffering and dying from sepsis. Okay, so let me move on to early appropriate treatment. So I think all of you should be familiar with the Surviving Sepsis campaign. It's an international guidelines for the management of sepsis and septic shock. And these guidelines cover multiple domains of sepsis management, from screening and early treatment, infection, hemodynamic management, ventilation, additional therapies, and goals and long-term outcomes. The 2016 guidelines did include the sepsis 3 definition. There was an update in 2018 that advocated for an hour one bundle. And then the latest guidelines were released in 2021. And I don't know if Mervyn Singer is on, or Mervyn Mayer is on the call. But Mervyn and myself are on the 2026 guideline committee, so those should be released at the beginning of next year. So this is an important study that was done, it's over 10 years ago, but it's an important question because these Surviving Sepsis Campaign guidelines are, sort of global guidelines, but how feasible is it to implement them in sub-Saharan Africa? In that study, granted it's now quite some time ago, the survey assessed feasibility of these implementing these guidelines in 185 hospitals from 24 African countries. And there was a massive disparity that was uncovered in the number of African hospitals that were equipped to implement all of the guidelines compared to hospitals in high-income countries, with only 1.4% of the hospitals surveyed from Africa compared to 81% able to implement the guidelines. And I think when I think if we were to repeat that study now, we would see that, there's definitely been an improvement, but that I would guess that the disparity still exists. And partly because there are context-specific challenges. So number one, we have in sub-Saharan Africa, there's limited resource to mechanical ventilation and recourse to mechanical, sorry, I think I said limited resource. I meant limited recourse to mechanical ventilation and ICU level care. And that means that so when a patient is getting aggressive fluid resuscitation, and if the patient is at risk for pulmonary edema, we are unable to kind of shift to giving a patient getting invasive mechanical ventilation to help them with their ventilation. because the availability of ICUs is much less than in settings where much of the surviving sepsis campaign guidelines are implemented. There's also challenges in providing continuous monitoring, sort of these at the bedside static monitoring versus kind of the dynamic monitoring, which can be seen in kind of high-tech ICUs. And there's also important differences in pathogens, which may result in different pathophysiology. And one example of this is the TB bloodstream infections. Noting that sort of some studies that have already been published and are in process, sort of question whether this group of patients would benefit from aggressive fluid resuscitation because of some of the risks to the kidney and sort of similar kinds of findings with other conditions like dengue. So I think that is just the framing of those guidelines. I'm going to now just kind of go through two key kind of areas of management. So timing of antibiotics and fluids, just to kind of unpack the evidence as we have them. So this on the left panel, in terms of timing of antibiotics, this study was sort of a groundbreaking study that was done by Anand Kumar and his colleagues in Canada back in 2006. And as you can see, this is really what guides our recommendations on sort of the time to antibiotics for a patient who comes in with sepsis. And as you can see, there's an increase of risk for death as time increases from the time of patient's presentation. But I would also note, sort of the error bars around each of these point estimates sort of overlap for a considerable portion of these early time periods, which says that really there isn't a true difference between several of these time points where the error bars are overlapping. And this kind of has played out in systematic reviews and meta-analyses. So in studies that have looked at timing of antibiotics in less than 3 hours and timing in less than 1 hour, there actually has been no difference in terms of risk for mortality, whether you were in the less than 3 hour or greater than or equal to 3 hour, or the less than 1 hour or greater than or equal to 1 hour. And so there is a bit of controversy around exactly what is the correct timing and what's the recommendation for that. And in fact, there's been a little bit more than just controversy. There's words have been thrown around. Editorial piece from colleagues in the UK called this sepsis hysteria. And when focusing on UK data, they said there was an unhealthy climate of fear and retribution in both the UK and the US. And that there was a doubling of antibiotic use, but there was no clear effect on mortality. And they also said that sepsis was seen in a tiny minority of patients, and most of them are over the age of 75 years old. Well, our colleagues from the African Sepsis Alliance and Global Sepsis Alliance were not too happy with that, and highlighted that there is a high mortality due to sepsis globally, with 80% of sepsis deaths occurring in low and middle income countries, and they indeed infect young and older patients, with 2 million deaths a year in neonates and children. And that retrospective studies and secondary analysis have shown that there's an important association between the increased transition from sepsis to sepsis shock and delaying antibiotics. So with all that, back in 2016 and the Surviving Sepsis campaign, to try and mediate between these two perspectives, the guidelines committee said it is our view that the target timings don't necessarily mean that these are exact inflection points, but they're meant to reflect the sense of urgency required in the initial management. And I think that is really the take-home point, that we need to get antibiotics in as soon as possible, and not to delay them. But if they're 1 hour or 3 hour, uh, perhaps we don't really have the evidence base to guide that. So moving on to fluids, the early goal-directed therapy was another groundbreaking study done in 2001, and in a single center that really randomized patients to receive what was usual care, and that included, sort of monitoring of blood pressure, urine output, and central venous pressure, to that plus what was early goal-directed therapy. And early goal-directed therapy included monitoring of central venous oxygen saturation, but also hematocrit, cardiac index, and VO2. And the River study, so the initial study in 2001, as you can see in the top line of this forest plot, that it demonstrated that survival was increased in patients who received the early goal-directed therapy study. But since then, there have been a number of large studies, the PROCESS study, the ARISE study, and PROMISE study, all done in different parts of the world, in North America, Europe, and Australasia, all showed that there was no difference between early goal-directed therapy and the kind of usual care. Um, I think important to highlight here is that none of these larger clinical, well, none of these studies really address the amount, the timing, or the guiding clinical variables beyond central venous oxygenation. And also to note that in the first 72 hours, yes, early goal-directed therapy did have much larger volumes, about on average of 13 liters. But the large trials, also had very high volumes in the first 72 hours of 7 to 8 liters. So really hard to know, exactly where's the point there in terms of cutoff of volume. And indeed, as we look at the evidence that's out there, for low and middle income countries, the guidelines are quite limiting. We did a review of 10 guidelines, and that were almost universally derived from evidence in high income countries. And the guidelines contain disparate recommendations on IV use. They lack specificity, and they were really unattainable in low-income countries given the available resources. Um, and then we know that there have been a number of clinical trials that have looked at fluids that have also kind of changed our thinking about fluids. The FEAST trial that was conducted or that published in 2011 was a study of 3,600 children with severe febrile illness, randomized in sites across Uganda, Tanzania, and Kenya, to receive either rapid volume expansion or to receive rapid volume expansion over an hour with either saline, albumin, or no bolus. And I think all of you have seen these results that I think were surprising to many of us, where the patients who received the albumin or saline bolus had a higher risk for mortality compared to the patients in the control arm. And we really, wanted, from this came a number of questions about, is this generalizable to other settings? And what about adults? So there was a smaller trial that was done in adults in Zambia called the SPSS trial. And in this trial, about 200 patients who were adults with sepsis were randomized to receive either the simplified severe sepsis protocol, which is a protocolized approach to providing fluids and vasopressors and even blood transfusion if particular criterion were hit, and then versus usual care. And the primary outcome was in-hospital mortality. These patients were kind of in their similar to the study I reported on earlier. So mid-30s, predominantly HIV infected and very sick with elevated lactates over 4. And as you would expect, fluid resuscitation was greater in the protocolized arm versus usual care, and vasopressor use was greater in the protocol used versus usual care. But despite that, again, we were quite surprised to see that patients who received the protocolized sepsis approach had a higher mortality compared to those who had usual care. And so now there have been studies that have been in higher income country settings that have looked at how to give fluids. And so the first of these is the Clovers randomized trial, which looks at early and restrictive versus liberal fluid management. And here, this is a large clinical trial done in North America of just over 1,500 patients randomized to two treatment arms. The restrictive one is prioritizing vasopressors and lower IV fluid volumes, and the liberal one is prioritizing higher fluid volumes before starting vasopressors. And here, this is a different population than the populations that we've been studying in Sub-Saharan Africa, but the average age was about 60. Lactates were about 3. All the patients had acute kidney injury, and about 10% of the patients were on respiratory support. And again, not surprising, patients in the liberal fluid arm had greater volumes of resuscitation, and patients in the restrictive arm had a greater percentage on vasopressors. And the time from getting your first vasopressor was quicker in the restrictive group. The primary outcome in this case was 90-day all-cause mortality, and lo and behold, there was found to be no difference in 90-day mortality when comparing both arms. And the serious adverse events also were no different. Similarly, the classic RCT, I'll go through this one a little bit quicker. It's a very similar trial, except in Europe. Patients in 31 ICUs were randomized to restrictive versus standard, a similar type of a patient population, although in this case, about 50% of the patients had respiratory support. Again, fluids and had a higher cumulative fluid balance. And primary outcome was 90-day all-cause mortality. And similar to the Clovers trial, no difference in mortality when looking at standard and restrictive approaches to fluid resuscitation. So really, I mean, when we look at the evidence, there has been a meta-analysis that looked at liberal versus restrictive fluid resuscitation strategies, and these are really unresolved. The meta-analysis shows, as the trials have shown, that there's no difference in outcome. And this has kind of translated into how to approach the 2021, or how to approach the sepsis patients in the 2021 SSC guidelines. So for fluids, patients with sepsis-induced hyperperfusion or septic shock, in the initial resuscitation, there is a suggestion that we provide a minimum of 30 cc's per kilogram within the first 3 hours of resuscitation. But after that period, the committee concluded that there's insufficient evidence to make a recommendation on a restrictive versus liberal fluid. In terms of antibiotics, the 2021 guidelines helped to break down antibiotic administration into whether or not sepsis is definite or probable or just possible, and whether shock is present or absent. So if sepsis is definite or probable, the recommendation is that antimicrobials be administered immediately, ideally within an hour of recognition. But if it's possible, and if it's possible, and if shock is present, then same, give them immediately within an hour if possible. But if shock is absent and sepsis is possible but not probable or definite, then prioritizing rapid assessment of infectious versus non-infectious causes of acute illness and administering antimicrobials within 3 hours if the concern for infection persists is the recommendation. Okay, so I'm getting to the end of this. Monitoring and ongoing treatment is our next area. And so just to kind of highlight, I talked about the IMAI District Clinician Manual as an example of sort of guidance that includes specific guidance around sepsis. And these can be accessed easily on WHO or just Google IMAI DCM. Or if you would like me to send you the links after this, I'm happy to do that. I mentioned already that this was originally done in 2011, but updated during COVID in 2020 in the Southeast Asia region. Um, and this is just kind of one approach, the IMAI Quick Check, which is a systematic approach to triaging and managing patients in low and middle income countries. And I know you can't see the panel on the left, but I'll talk you through it. So just this kind of wall chart is broken up into emergency signs, first line emergency treatment. If a patient has trauma, also to consider things, and then continuing with urgent management. And so, as an example, if we look at a circulation emergency sign, and that's patients with a weak or fast pulse, or prolonged capillary refill time, or bleeding, or severe trauma, then the first line emergency management is proposed here. And also considering trauma, and then what to do in terms of your differential diagnosis in continuing with urgent management of patients with emergency signs. So this quick check wall chart corresponds well with the district clinician manual, and these trainings we've implemented in Uganda and Sierra Leone and elsewhere. Yeah, I mean, is kind of an approach to help us manage these really critically ill patients in settings where perhaps human resources or other resources are constrained. The sepsis guidelines specifically kind of are time-based, and here I show the first 2 hours and using the same rubric of recognizing that the patient has sepsis, fixing the physiology, treating the infection, monitoring, recording, and then responding to any sort of abnormalities in your monitoring and recording. I think during COVID, if not before, many settings got familiar with the news, the early warning scoring system. And this, again, is another way for rapid response teams or people who are kind of monitoring sick patients at the bedside, an easy way to determine whether a person is going sort of deteriorating or is improving in condition. And in fact, the guideline, sort of going back to what I was saying about the Q-SOFA, the 2021 Surviving Sepsis Campaign guidelines recommended against the use of Q-SOFA alone compared to SIRS or NEWS or any of these other early warning score as a single screening tool for sepsis or septic shock. So some potential solutions for assessment and monitoring of sepsis patients in resource-constrained settings. The Andromeda Shock trial was an interesting trial, and the Andromeda Shock 2 trial is underway, maybe just finished, and we're waiting for the trial results. But it was an important study done in South America. These are adult patients with septic shock who were randomized to a step-by-step protocol over the course of 8 hours using two different resuscitation strategies. So resuscitation targets were either guided by capillary refill time or normalizing or decreasing lactate levels. The primary outcome was 28-day mortality. Again, this was more of a high-income country setting in ICUs where the average age was about 60. Here, although the primary result is not statistically significant, there is a signal for a decreased mortality in those patients who had their resuscitation guided by normalizing capillary refill time. So, like I said, this trial, there's a follow-up trial that's underway. that really is trying to get to the bottom of what this signal was in the initial Andromeda shock trial. But as you can imagine, having something like capillary refill time to help guide the management of patients at the bedside in our sub-Saharan African context would be a bit of a game changer. So I think let's keep our eyes out for the results of that trial. Some other potential solutions, I talked about, bedside tools like capillary refill testing. There are other things like skin modeling scores, which you can see there on the right, and skin temperature gradients. And then in terms of fluid resuscitation and fluid responsiveness, there's the passive leg raise in a sort of systematic review for this guidance. There's a weak recommendation with evidence to look at passive leg raise. The procedures are there on the right. And even in the Surviving Sepsis campaign, going back to that point about static versus dynamic measures to guide fluid resuscitation, the committee suggested to the use of dynamic measures over static. And these dynamic parameters include looking at response to a passive leg raise or a fluid bolus using things like stroke volume or stroke volume variation, pulse pressure variation, or echo where available. So let me end with the last sort of area, which is recovery and rehabilitation. This is a study that was published back in 2019, looking at long-term mortality in adult sepsis survivors in the UK. It was an observational cohort of almost 100,000 adult sepsis survivors from almost 200 critical care units in England. And these patients were followed for 6 years. Similar demographics to the other high-income country studies I've reported on, the mean age being 60, majority male and majority white. Mortality in the first years was 15%, but over the subsequent 5 years, there was an increase in 6 to 8% of mortality per year. And independent risk factors included age, sex, race and ethnicity, severe comorbidities, dependency, non-surgical status, site of infection, number of dysfunctional organs, and Apache 2 score. So I'm coming back to Mr. Musoke. I'm sure you've been, sort of wondering and thinking about what was going on with him. And just to cut to the chase, that he was severely ill. He came in, he had, hypotension, likely shock, and evidence of thrush on his exam, which suggested he might be HIV infected. And we know, sort of from studies that we've done of similar patients to Mr. Musoke in Uganda through the African Research Collaboration on Sepsis, that his risk for mortality definitely increases over time. These are some preliminary data from the ARCS cohort study done in Uganda, where, as you can see, as we go from a in-hospital mortality of 20% to 3 months, which is approaching 40%, to 12 months, which approaches 50%, that not only is there a high risk for mortality for someone like Mr. Musoke in hospital, but that mortality persists if he were to recover from his hospitalization over time. And trying to understand exactly what might be contributing to that high mortality in patients who have survived from sepsis is critical to our understanding of improving outcomes from sepsis in sub-Saharan Africa. In addition to mortality, we also need to know about morbidity, and we know that about half of these patients recover, but a third of patients die during the following year, and a sixth have persistent impairments, and these impairments may be cognitive in nature or mental health conditions, and quite a high proportion end up getting re-hospitalized within 3 months with infections or heart failure exacerbation, depending on their comorbidities. So these post-discharge data are from high-income countries, but we really need to understand more about sepsis morbidity and mortality in low and mid-income countries, particularly in sub-Saharan Africa. So that is where kind of the stairs, you've heard about stairs already. And we have, through stairs, expanded the network of sepsis researchers across Sub-Saharan Africa. I'm sure you have seen the website, but feel free to check out that QR code that gets you straight to our website to understand more about what work we are doing in stairs along the patient care continuum to try and understand these gaps and also potentially help to fill our knowledge gaps along that continuum. So some take-home points. We know that sepsis is a global health problem, and there's a disproportionate burden in Sub-Saharan Africa. Using a patient care continuum framework can be helpful to uncover key areas for sepsis research and quality improvement at different points in the patient journey. We need to do more research in our settings on sepsis management to identify potential differences across key subgroups. And these include patients with HIV infection, malnutrition, non-communicable diseases, and the delivery of sepsis care in ICUs versus non-ICUs, because we all know that predominantly sepsis patients are taken care of outside of the ICU in many African settings. And finally, evidence-based guidelines for non-high-income country settings need to strike a balance between achieving universal standards and tailoring them to address context-specific differences. And in short, low resources should not translate to low quality. So thank you very much. I'm sorry if I went over. I am happy to stay on longer if there are questions or anyone wants to discuss anything. Thanks very much.
Shevin, thank you so much. Can you hear me? Yeah, I think so, right?
Yes. Yeah.
Thanks a lot. I mean, the first thing I want to emphasize as well is that if there are any questions, please, now's the time. You can either put any questions in the chat, and Elaine is going to be happy to sort of look at them, read them, or, and I can see that this is already happening. Please just put your hands up. Yes, I see that Emmanuel, I see a hand. Please, Emmanuel, give us your question, please.
Okay, thank you so much for the opportunity to talk. It's a pleasure. Thank you so much, the presenter, for your excellent presentation. I just have a few more comments to add to some of your submissions, which I feel is going to be of great benefits to this audience here. First and foremost, is the point that I want to make is don't wait until you have all the figures. Don't wait, especially in low resource settings, before you can make up your mind as to what is happening. Figures sometimes may not tell all the truths. So be careful with the figures. That's the first point that I want to make regarding all these scoring systems that are in evolution. Then the second point that I want to make is, yes, what a new scoring system should not set aside completely the previous scoring systems, because inherent in every scoring system is both its own merits and its own demerits, especially in low resource settings. And experiences will help you master what works best in your climb and how you can have a synopsis of scoring systems. Yes, there's a place for a synopsis of these scoring systems that the presenter has dutifully presented. So the point is we can marry scores in our decision-making processes. That's the second point that I want to make. Then the pediatric considerations. They have a number of atypical presentations, and the clinical picture of the patient that you happen to be managing is very, very important. Some of them may not, especially in the decompensating phase of sepsis, some of those mounting responses, those responses may not be in the compensatory form. It may be in the decompensatory form. Bradycardia, tachycardia may switch to bradycardia. Tachypnea may switch to hypopnea. So these clinical pictures are very, very important. Also in the labs, aside the lactate, etc., etc., there is a gene modality in the presentation of some of these patients, which accounts for the context specificity that he was talking about, which the PCRs and some of these things is going to give credence to. Then in the choice of fluids, vasopressors as it may apply, we must know when not to switch to vasopressors, when to hold on, when to give vasopressors. These are some of the highlights that I want to make. Then the invasive procedures may also introduce sepsis, cannulations, catheterizations, as it may apply. So these are some of the things that can confound the clinical presentation of some of these patients. Then lastly, I will want to say that, yes, there are quite a number of etiologic factors that he has talked about, the fungi, etc., etc. But there is the place for mycobacteria and prions. So in some of the, which may confound the presentation of some of these sepsis. So the take home here is, don't let us set aside all the previous old scoring systems. Let there be room for synopsis of scores. Then scores may not tell the whole truth. Look at the clinical presentation of the patient and marry it. Then prognostication value, monitoring and evaluation value, and the diagnostic value of some of these scoring systems are relative. Thank you so much. It's Dr. Emmanuel Oluyinka, Professor of Emergency Medicine, Nigeria. Thank you.
Thank you, Dr.
Brilliant, Emmanuel. Thank you
Thank
for
you
that.
so
That's
much.
an amazing summary, and I think everyone can gain has gained from your insights and wisdom on that. Thanks very much.
It's true. I do have to say I do sort of double down on the experience as a clinician. Obviously, it's something that we cannot leave outside the door. We sort of have to use what we know. But yes, I think we've seen a great picture of what's out there in terms of data as well. And we've also seen that there's a lot of room for creating more data and more insights still, especially in the Sub-Saharan African context. Tafese, I can see your hand up too. Please, can we have your question?
Yes, thank you, Vitrud. Thank you, Shevan, for wonderful, nice presentation. Really, we learned a lot. My question is, Shevan, it is about early antibiotic initiation and the resistance era. So what is your recommendation on that? Like broad spectrum or combination of antibiotic? Because, in African setup, it is not easy to get the ST result.
Yeah,
Thank you.
Sorry, did you finish Tafese, or did it cut out?
Yes, I finished.
Okay. No, yeah, really important question, Tafese, and absolutely, we may not be able to get the susceptibility testing once we identify a pathogen in the bloodstream. But I think increasingly there should be at least regional antibiograms, right? Like, so that you kind of have sentinel surveillance of the types of resistance patterns that are circulating within sort of communities or regions. I mean, I think it will depend on resource. So if every hospital in your community has access to antibiotic susceptibility testing, then all good and well. But if only one does in the region, that's still quite informative. So you know that your E. coli's have extended spectrum beta lactamases. You do need to, when someone comes in, then your empiric treatment may need to be more broad spectrum. You may need to do double coverage. You may need to use if you have methicillin-resistant Staph aureus that's common in the community, then you may need to start with vancomycin rather than something that would be susceptible to methicillin. And so I think we often are sort of walking and trying to be guided within the dark. But I do think that there is ways for us, even despite resource constraints, to get information that is relevant to our country or to the region. As small as you can get, having periodic susceptibility patterns that are reflecting what's happening kind of in or near your hospitals should help to guide the care that you are delivering at your hospital. And then that obviously has downstream impact on kind of the types of antimicrobials that you have to procure, and that at the level of the health ministry needs to get into the country, so that patients who are coming in with sepsis with drug-resistant infections have the types of antimicrobials that are necessary to manage those types of patients.
Thank
Thank you.
you, Professor. I hope that, answered your question. John, I see your hand up too. Please go ahead with your question.
Yeah, thank you very much, Wilfred. Shervin, that was a brilliant talk. I want to weigh in on both questions from our colleague from Ethiopia quickly. I think we also need to look at the existing guidelines to provide us with guide. Once we have the guidelines, I mean, rigorous effort is put into development of the guidelines to ensure that the standardization of care. So doing, you have quality and improved care, so that we are not doing things that you go in and do that. I know that that's not quite to refine that. I think we need to ensure that wherever we are, we develop or standardize. We adapt the existing guidelines to our setting, which to me will help us improve quality of care. And that's very important. We can't leave the guidelines and do anything after all. The second point I want to raise about that is the fact that, we've had a series of definitions, and now sepsis 3, both pediatric and then the adult patients have come from sepsis 3 definition with operationalization guidelines. Whilst these are guidelines, it's an attempt to refine and make it easier so that we are able to quantify sepsis very well, and we are also able to manage sepsis in a standardized way with quality at that's my addition to that. Concerning and also I have 2 points. In my hospital, for instance, if we look at the organisms we are isolating in ICUs, comparing 2 ICUs, at least from the adult to the slight are different. I mean, if we can look at it that way. Then the second one is that even within pediatrics, organisms somehow different. And as a result of that, this should inform specific organisms to appropriately select and prescribe antibiotics that the patients need in order to improve patient outcomes. Thank you, Nova.
John, thank you. It was a little bit hard to understand, but I think I personally got about maybe 60% of what you said. I hope that Shevin got another sort of percentage of what you said. Do you want to answer to John, Shevin?
Yeah, John, I don't think you had any questions, but from what I could understand, I agree with all the points. All valid and really important for us to be considering context, sort of adaptation of what we have at at our hands. The only thing I will add to the adaptation is, again, that, sort of sitting with guidelines that are often transmitted from other settings, is not always that helpful. And so just re-emphasizing the point of getting context-specific evidence to drive the guidelines and the care that we deliver to the patients in settings where you and I are working, I think is also an aspiration, and recognizing that it takes time for the guidelines to be developed, for the evidence to be generated, et cetera, but that we are always kind of thinking in both ways. Let's get the guidance from wherever it comes. Let's adapt it, and then let's identify those gaps so that we can have the context-specific research to guide in a way that really tailors the types of patients to the types of patients that we end up seeing.
Thank you. Yes, exactly. I mean, this is probably the part where I also very much agree with John. I think you mentioned that we are to, in a way, take what we have, and Shevin adds that we sort of also have to work to sort of adapt move the guidelines into a space where they also represent the Sub-Saharan African setting. But until we are there and we're working on it, as you have seen, I mean, there's like a whole bunch of research going on in the Sub-Saharan African setting right now. As long as we're not there yet, we do have to, and the guidelines also say that because we have to look at ways for quality improvement in the specific setting that we're working in, and there is value in looking at our own setting wherever we are and sort of develop local sort of protocols for quality improvement with respect to what's needed for our sepsis patients. That's that's both is true in a way, right? We look at what we have and use it, adapt it, but also work towards making it better and more relevant for the Sub-Saharan African context. I don't see any more hands up right now. Helen is shaking her head, so there are no more questions from the chat. I just want to at the end of this, we're already over a little bit over time, but give me one more minute to mention that, and Helen has sent the link to the chat already. We will be uploading. We are recording these sessions. We will be uploading them online for everyone to look at them at any time. And there is actually a place now for this, and we have started uploading the first sessions on the learning platform, which is part of the Sepsis learning platform, which is part of the STAIRS website, which Shevin has also mentioned in his talk. So please, like a big invitation to everyone to just visit the website. Ellen has shared the link in the chat. We're happy to also share this in an email whenever we send the next invitation for the next session in 2 weeks' time. And please come and look online at the sessions that are already uploaded at this point. There's also much more resources, and we will keep adding resources to the learning platform over time. And you're very, very welcome to just come and visit the website whenever you have the time. Thank you very much for coming to the session today. It's been a full house. I'm very happy to see this. Thanks to Shevin again for doing this. And yes, I hope to see you all again in 2 weeks' time for the next session, for the next upcoming session of the Global Sepsis Lecture Series. Thank you so much.
Thank you very much.
Thanks, everyone.
Thank you. Bye.